Alright, now let's go over the information on blistering skin disorders. The first two we've actually already talked about to some degree when we were discussing the desmosome and the hemidesmosome. IgG antibodies against the desmosome gives which disease? Pemphigus vulgaris. You'll need to be able to distinguish Pemphigus vulgaris from bullous pemphigoid. Okay, so Pemphigus vulgaris causes segments of epidermis to lift off away from one another, which leads to the formation of intraepidermal bulli. Do you remember the term for this skin finding? Acantholysis. It can be very severe. On immunofluorescence, you'll see a net-like pattern because the antibodies can be found throughout the epidermal layers, between keratinocytes. Do you remember where the hemidesmosomes are? The basal layer of the epidermis. What might you expect on immunofluorescence of bullous pemphigoid? A line instead of a net. This means when the hemidesmosomes are destroyed, the epidermal layer lifts off, and the dermal layer is one untouched piece underneath. On your exam, tense blisters are more likely to indicate bullous pemphigoid, whereas flaccid intraepidermal bulli are seen with pemphigus vulgaris. Also, Nikolsky sign, or easy separation of the skin with gentle stroking, is seen in pemphigus vulgaris. If the skin doesn't separate with a gentle touch, it's more likely to be bullous pemphigoid. Another distinction is that pemphigus vulgaris will affect the skin and oral mucosa, while bullous pemphigoid only affects the skin and will not affect the oral mucosa. So which would you rather, pemphigus vulgaris or bullous pemphigoid? Pemphigus vulgaris is potentially fatal, and your skin sloughs off with a slight touch, so I think that I would go with bullous pemphigoid. Let's have a flash quiz. What is Nikolsky sign? It is skin that separates with a gentle application of tension. Ouch! The next blistering skin disease is dermatitis herpetiformis. When you think about the word, it quite literally is skin inflammation that appears like a herpes infection. If you look at this under the microscope with immunofluorescence, the appearance is that of IgA at the tip of dermal papillae, which causes the tips of the papillae to light up like snow caps on mountains. The papules and vesicles are itchy and are usually found on the extensor surfaces of the skin. What is this particular skin manifestation associated with? You should think of celiac disease, which in some cases may precede the appearance of GI symptoms. Do you remember what type of hypersensitivity reaction this represents? Type 3 hypersensitivity reaction, and it's due to the deposition of IgA immune complexes. The final blistering diseases are erythema multiforme, Stevens-Johnson syndrome, and toxic epidermal necrolysis, which probably shouldn't be thought of as classically blistering diseases. EM and SJS are the two ends of a spectrum that occur as a result of drug reactions, much like the spectrum of cellulitis and necrotizing fasciitis. Toxic epidermal necrolysis is severe SJS that affects greater than 30% of the body. EM is the most benign reaction. EM classically shows a number of different lesions, usually with macules, papules, and vesicles, and some targetoid lesions, which is a classic finding. Many drugs can cause EM, including sulfa drugs, beta-lactams, and phenytoin. Additionally, you may see EM as a result of certain infections, like mycoplasma and HSV. A much less common association made on the board exams. The other even less common possibility is that EM results from cancer or an autoimmune disease. It's worthwhile to know these associations exist, but you should keep EM strongly linked to adverse drug reactions for the purposes of the boards. SJS, in contrast to EM, also has a more concerning skin finding, usually including bulli with necrotic areas, particularly orally, and is found along with systemic signs like fever. What's it called if more than 30% of the skin is involved? TEN. This is life-threatening, and the skin is literally sloughing off. Let's have a flash quiz. What is the common cause of EM, SJS, and TEN? Drug reaction. And now we've reached the final section of skin disorders, the miscellaneous disorders. While these couldn't be categorized into the groups that were already listed, they are definitely worth remembering because most of them have certain pathognomonic findings to help you recognize them clinically. Also, a few of these are indicators of underlying disease. The first of these diseases is acanthosis nigricans, a classic example of how a skin finding can indicate underlying disease. Do you recall the skin layer affected in acanthosis nigricans? Hyperplasia of the stratum spinosum. What should you suspect with these skin findings? Insulin resistance, like diabetes, or a visceral malignancy. The next lesion is actinic keratosis, a small, rough, red or brown papule that is considered premalignant. Do not forget that these are premalignant lesions. Very important that you remember that. What lesion can derive from these small, rough, erythematous papules and plaques? They can become squamous cell carcinoma. It's thought to be associated with sun exposure. Erythema nodosum is inflammation of subcutaneous fat, particularly on the front of the shins. There is a huge differential for what diseases have EN as part of their presentation, and include fungal infections and TB, as well as leprosy, strep infection, sarcoidosis, and Crohn's disease. The next lesion is lichen planus. The skin lesion is classically and always described as pruritic, purple, polygonal papules. Histopathologically, lichen planus appears with sawtooth infiltrations of lymphocytes at the dermal-epidermal junction. What virus is this lesion associated with? Hepatitis C. I like to remember that lichen planus, with a P, shows pruritus, purple, polygonal papules, all P's, and is associated with hepatitis C, which also has a P in it. It kind of works. So what's this lesion? It's pityriasis rosea. Though you likely won't see it, it's worth knowing because it's marked by two classic skin lesions. The first is the herald patch, usually a small patch that occurs initially and heralds the later papular eruption that occurs in a Christmas tree distribution. What do you need to do for this rash? Nothing. The disease requires no treatment, and it goes away by itself. Finally, let's talk about the common sunburn. What cells die during sun exposure? UV radiation from the sun induces apoptosis of the keratinocytes in the epidermis, predominantly caused by UVB radiation. Excessive sun exposure and blistering sunburns are risks for skin cancer. So, you guys should definitely wear sunscreen. Let's have a flash quiz. Was purple pruritic and presents with polygonal papules? Lichen planus, also associated with hepatitis C. Skin cancer is an incredibly common type of cancer, and in many cases, not a life-threatening one to have. There are three main types: basal cell carcinoma, squamous cell carcinoma, and melanoma, all of which have classic appearances that you should be familiar with for your boards. Basal cell carcinomas occur commonly in sun-exposed areas. They are locally aggressive, but they tend not to metastasize. BCC is the most common skin cancer. It will definitely be on your boards. The classic description is a central ulceration, but may also be described as pearly papules with rolled or heaped up borders that show telangiectasias. Once you see it, you'll never miss it. Do not confuse this nodule with central ulceration with a cyst. How else could it be described? A non-healing ulcer, perhaps, or a scaling plaque. What should you expect to see if you do a punch biopsy of the lesion. Palisading nuclei. Squamous cell carcinoma is a skin cancer that is thought to arise from another skin lesion that we just discussed. Can you remember which one? It's actinic keratosis. A variant on this theme is a keratoacanthoma, which usually grows fast over the course of weeks, but then regresses within weeks, after that spontaneously. SCC is usually expected on the hands and face, and may have serious local invasion, but will rarely invade past the basement membrane. On gross appearance, the lesion appears red and may be ulcerated. Histologically, the key finding is the keratin pearl. There are 3 associations with SCC that you should know. It is associated with sunlight exposure, and commonly appears on the face, lower lip, ears, and hands. It's also associated with immunosuppression, arsenic exposure, and prior chronic draining sinus tracts. What bacterial genus typically causes chronic draining sinus tracts that discharge sulfur granules? That's right, Actinomyces. The final type of skin cancer is melanoma. This is a serious one. Why? Because unlike SCC and BCC, melanoma can metastasize. The classic question is, what aspect of the tumor affects its likelihood to metastasize? And the answer is, no matter how it's phrased, is its depth, known to surgeons as its Breslow thickness. Which kind of makes sense, so it's easy to remember. The deeper a skin cancer goes, the worse the prognosis. The lesion itself is described with the ABCDE memory aid. A for asymmetry, B for irregular border, C for more than one color, D for diameter, greater than a pencil eraser, and E for evolution over time. Risk factors for melanoma include fair skin and increased exposure to sunlight, as well as a prior history of a dysplastic nevus, as this can be a precursor lesion. There's also a tumor marker that can be used as a staining technique if there's a concern for melanoma. Do you remember it from the path section? That would be the S100 marker. Just think of S as standing for skin. S100 is normally present in neural crest cell derivatives. Can you name a few? Think of Schwann cells, melanocytes, and glial cells. So you may use S100 as a schwannoma marker as well. Of course, if the melanoma is on the skin, it's usually easier to know it's a melanoma. But remember that melanoma has many different forms. The ABCDE mnemonic we discussed is best for the common type of melanoma, which is called superficial spreading melanoma. But there are many other types, including nodular and amelanotic or colorless. Also, 20% of cases with metastatic melanoma present without a primary melanoma on the skin, presumably because it was small and was defeated by the immune system already. So if you get a question about metastatic melanoma, remember that melanoma is a mean cancer. It does not follow any rules, and it can quite literally go anywhere in the body, from your gut to your liver to your bone to your brain to your eye. If you ever get a micrograph of a MET though, it's pretty easy to figure out it's melanoma. Melanoma should be uniformly darkly pigmented in any picture that you see on step 1. So what should you do for these patients? Excise with wide margins. What if you have a patient with METs? You should check the patients for the BRAF V600E mutation. And because of that, you can consider giving vemurafenib. What is vemurafenib? It's a BRAF kinase inhibitor. Let's do a flash quiz. What looks like palisading nuclei on punch biopsy? The answer is basal cell carcinoma. Squamous cell carcinoma would show nests of cells and perhaps a keratin pearl, and melanoma would show atypical cells with lots of pink cytoplasm invading the dermis.